Hey everybody, hopefully you're all doing well. Let me know if you can hear me. Loud and clear, fantastic. Hey Allison, congrats on your treasurer position. Saw that in the SGA announcement. Yeah, no problem. I'll get started here in just a few minutes. Oh, it's going pretty all right. Yeah, it's going into another weekend, much like the rest of the week, just at home, you know? How about you guys? How are classes going? That well, huh? Week was rough. We're almost through. That's good. That's gonna be a lot of weeks coming up. I won't lie. Haven't dropped out. Oh, okay, Kyle. That's a low bar to clear, my friend. Everyone should still be in. No one drop out. This is a great program. Just abnormal times, I will say. It's like saying, "How was your week?" It's like, "Well, I'm still alive." It's a low bar to clear, but I guess it's good for some people. Yeah, these terms aren't too fun for anyone, but you know, gotta get that degree. Start helping people out there. Do you guys have anything to do at 2:30? This Friday at 2:30 classes always seem to be the worst for you guys. It's like you've lost all energy to live at that point. You're just ready for the weekend. Working on PD lab, but yeah, I keep hearing about how those have been kind of intense. Hey, cassette. Yeah, those are different. I think it's kind of interesting. At least like you get an attempt where you can do like your most perfect work and like get it all done in that one video. You know, you can always see if you miss something. Let's see. Yeah, we don't meet till next Tuesday again, so that'll be good. Okay. So you guys are doing the abdomen cardiovascular one now? Is that what you're doing? I think. That's what I heard through the grapevine. All right. Well, it's 12:30, so I'm gonna go ahead and get moving here. All right, starting to record. Let's see. Kyle says real struggle to get that video under 25 minutes. Yeah, that's what I heard. I heard the 25 minutes is tough. But you know, I think there also is some benefit to that too. If you kind of think about, you know, learning to be efficient and how you're going through those things, you know, it may seem like kind of arbitrary, but you know, when you think about in the real world, once you get out there and you're practicing, and one, your efficiency goes up, and then two, You'll also find that like you just gotta see a lot of patients sometimes too. Like the ERs are busy or the clinic's busy. So, but yeah, and two, like you'll also find that you'll be able to kind of run in like parallel tracks at the same time. So where you can like be talking to the person, doing your test at the same time. So that all comes with time and efficiency. So, it's a struggle now, but it will get better for sure. So don't you guys worry about that too much. But anyway, yeah, so if you have questions, please go ahead and put them up either in the chat or we have that sticky board, and the link is in the class. I don't see too many people utilizing this too often, which is it's a good opportunity to get some anonymous questions in there. So if you're curious about something, just let me know. Otherwise, we'll get started here. All right, so we are talking about Unit 3. This is where we get really sort of in depth in terms of the kinetics that I've been kind of alluding to this whole time here. So when I say kinetics, what I'm really talking about is, again, what the body's doing to that drug, right? So we talk about dynamics being what the drug is doing to the body. This is the kinetics. Like, how does the drug get absorbed? Where does it go to in the body? How does it get metabolized? And then finally, how is it excreted? Then we'll talk a little bit about how those factors have a role to play in terms of like dosing and how we can maintain appropriate levels of drugs in the body, how we're going to load the body with that drug potentially, a steady state, and then some toxicity stuff. And so this will be a pretty big lecture in terms of like good takeaway concepts I want you to get out of this. Like definitions and stuff, you need to know that to be able to get into this stuff. But like once you know that, that's kind of it. This is like, a lot of really good concepts. It'll kind of help you out in all future pharm classes as well, right? So anyway, so you can kind of picture what the kinetics really look like if you look at this picture here, kind of going from, say you take a drug, say you take a tablet, you just swallow it. The drug liberation and then the absorption that occurs here is kind of the first step we'll hit on. The free drug that actually gets into the circulation can go many different places, right? So you can find some of it will be bound up by protein in the blood. This may be albumin. This may be, there's various proteins there. You will find that also during that component, you'll also find some of it will get to the liver because it's naturally circulating through. And that's where we get to biotransformation. That's where we get to the metabolism that actually occurs there. And so you have metabolites, and you can find that excretion can either happen from these metabolites or actually straight from the liver in a lot of cases, and that's the clearance. Obviously, the pharmacodynamic features here we'll talk about more in the future. We've kind of already talked a little bit about, but once it is in the central compartment, then it can then partition out into the tissues where it can actually have its therapeutic effect. It can hang out in the tissue, so you get those reservoirs we talked about. This will be important in terms of distribution. We'll see in a little bit. And then some of those unwanted actions, some of the side effects and things like that you can see that will pop up. So let's get into absorption first. This isn't as big of an issue if you're dealing with a drug being given intravenously, but for really everything else, this really does matter. And so when I say permeation, and some of you may be like, man, this is like basic biology stuff. I learned this back in like AP Bio or whatever biology class you learn about this stuff in. Actually, I came from such a podunk area. We didn't have AP classes. I learned about this stuff when I did dual enroll to learn this stuff. But anyway, so community college all the way, right? But anyway, so you see this permeation here. Basically, we're having movement of objects, movement of molecules across these barriers. And so you can imagine cell walls and a lot of different membranes being composed of these phospholipid bilayers, right? And so things need to move across there. Things tend to move via passive diffusion, where they go from areas of high concentration to low concentration. That'll be a big one for just the passive movement of objects. And so this can happen with electrolytes. It can happen with drug molecules. It kind of happens with everything, really. And again, it's a passive process, so it is not... there's no ATP being expended here to make this happen. And so we talk about aqueous diffusion. I'll probably talk about this in conjunction with a lot of lipid diffusion as well, because that lipid diffusion was actually crossing that membrane. And again, this could be any membrane we're talking about here. It could be the GI tract. It could be the blood-brain barrier. It could be lots of different things. And so with the aqueous diffusion, that's driving a lot of that diffusion from high to low concentrations. And then the lipid diffusion, what's kind of keeping things from moving by providing these sort of semi-permeable membranes here. And we're actually going to find that depending on a lot of factors, you can find that the ability for these molecules to cross can change pretty greatly, especially when you're looking at things like the whether the chemical itself is a weak acid or base, and also the pH of the solution that it is dissolved in, and so that can actually make a big difference. So we'll talk a little bit about the dreaded Henderson-Hasselbalch equation here in just a little bit. There are other means for this to occur as well. So you may have some passive diffusion of things through aqueous pores. That is possible for sure. There's also means of having active diffusion, right, where you actually have things that are being processed through by certain transporters. Frequently, they require energy for that to occur. So it'll take the ATP and bring it back across the cell membrane. What's interesting here too with the active transporters is that it can go against the concentration gradient, which is something that just can't happen with aqueous diffusion. So I always think about the sodium-potassium ATPase pump, right? Because that's really important for resting membrane potential, for the neurons, for the heart, I mean, like really for everything. And that's an active pump that is pumping against the concentration gradient, right? It's 3 sodiums out and 2 potassiums in, I believe, right? And so that's against the concentration gradient. So to make that happen, that's where the ATP comes in. Also, one thing to note here as well is that these, with like passive diffusion, it's really, as long as there's a big concentration gradient, you're going to get a lot of flux going through, but you can't actually saturate these proteins here. That'll be another thing we'll talk about, is this kind of saturable sort of nature of these, where once all the proteins are bound up, then they're kind of stuck and moving at a very fixed sort of rate there. That'll be important later. And again, this aqueous diffusion happened with the largest aqueous compartments of the body, sort of think about the blood and things like that. A lot of these aqueous pores are helpful, especially with like the blood vessels and the endothelial lining. Things can kind of move between the intra and the extravascular space. And this is really governed by something called Fick's law. And this actually applies to some lipid diffusion too. And again, we're not going to do any actual math based off of this, but the thing I want you to notice are what the variables are representing and what they do for us. So when I say flux, I'm just talking about the movement of these molecules across the membrane. First thing here is a concentration gradient. So this is an important one, going from the concentration on the outside of the membrane, C2 being the concentration inside the membrane. What you find here is the bigger the difference is here, the bigger the concentration gradient, the more flux happens, right? So again, going from that higher concentration to lower concentration, well, the higher that initial concentration is, the more flux you're going to have going on there. Where it gets a little bit more interesting is when you're talking about this other factor, these other variables here. So for instance, like surface area is really important. Now, if you were to look at a cross-section of the small intestine, you wouldn't see it as just being a flat tube. It's actually quite convoluted. There's all those microvilli and everything that increase surface area. That's why it's such a great absorptive area. You can also find, too, that like how much skin is covered with the drug can affect how much is being absorbed. So surface area is really important. The more area covered, the more they can be absorbed, right? You also want to think about the permeability coefficient of the drug itself. So some drugs tend to be more lipid soluble and have an easier time crossing than the other. So that's one thing to consider. And then notice here the thickness is in the denominator. So this will be inversely proportional to flux. The thicker the membrane you have to get through, the more difficult it will be for that flux to occur. So if you think about things like if you were to put some medication on, say, your armpit versus the soles of your feet, right? Going from an area of relatively thin skin to thick skin, well, your armpit would probably have better absorption than something like the soles of your feet, right? Because it's just much more thick skin. So all those are important, and a lot of that is pretty common sense, I feel. But it'll make more sense when you look at a picture too in just a moment here. But so again, as I mentioned, larger concentration gradients, more flux, right? You'll find that drug absorption happens faster from large surface areas like the large intestine versus, say, something like the stomach with a relatively small surface area. This will be faster with organs that have thin membranes. So like the lungs, you can get really great absorption with the lungs versus like the skin is going to provide more of a protective sort of barrier. Doesn't mean nothing can get through the skin, because we certainly know drugs can be given transdermally, but it does provide a barrier there. And this is the body's way of establishing a steady state based off these different factors here. When I say steady state, it basically means the the control between the amount of drug into the system versus those that are leaving the system. So it's kind of this balance we're going to talk about much more towards the end of this talk. So this picture I think is helpful to consider Fick's law. We're talking about the concentration gradient from the outside to the inside of the membrane, surface area. So the bigger this is, the more flux you're going to have. And then looking at the thickness of a thinner membrane. So something like the mucosa of the rectum, very thin, very good absorption from there, versus say the skin is always kind of the best example there. So much thicker in terms of where the skin is. So that's going to have an inverse effect on the actual flux that happens. So when I mentioned lipid diffusion, this is where it gets a little bit more complicated, because those lipid barriers tend to provide pretty significant barrier to absorption for some molecules. Some things are just so lipophilic they can cross, no problem there. But what's interesting is that for many molecules, the pH of the medium that the drug is dissolved in can actually help either facilitate or prevent this from occurring. And because of that pH, it can actually change the ionization state of the drug. So what do I mean by that? So what I mean is basically whether or not that molecule has picked up an extra hydrogen ions, whether or not it is protonated or unprotonated, can have an effect in terms of how well it's going to cross. And why is that? What we're actually going to find is that in some cases, protonation will cause the molecule to become charged. When it's charged and has an extra little plus on it or a minus on it, it becomes more polar, and thus the water solubility goes up, but lipid solubility goes down. So it's going to have a harder time crossing with charged membranes, or charged molecules. With uncharged molecules, you're going to find that they tend to be more lipid soluble and water insoluble. So for things that go into solution, maybe being a little polar is good, but then when you want them to cross that membrane, being uncharged is going to be better in that situation there. And how we determine whether a drug is in that protonated state or not, or is in a charged state or not, is based off the drug's pKa, the pH, of the medium that it's going to be dissolved in. So that's how we describe that. I'll show you some pictures that kind of give you a better example of what that looks like. And we'll talk about how that relates back to that Henderson-Hasselbalch equation. So for our discussion here, pKa is the acid dissociation constant of the drug. So every drug will have a pKa. There's also a pKb, but we're not going to get into that. And basically, if you look at a graph and you were to look at the ionization state of the drug, as long as the pH of the solution equals the pKa of the molecule, you're going to find it actually gets into this like 50-50 split between being protonated and unprotonated. And again, all these molecules are in flux. It's just a matter of like kind of what the general proportion is of them having picked up a proton versus not. So at the pKa, if it's equaling the pH, then it's 50-50 split, right? And there'll be a picture that will illustrate this a little bit better in a second here. When we're talking about the nomenclature here, a weak acid in the unprotonated state is going to be a charged molecule. It's going to have a negative charge on it. When it picks up a proton, this hydrogen here is going to be the uncharged state, right? And remember, what makes a solution acidic? Well, it's that hydrogen ion concentration. So in acidic mediums, there's a lot of hydrogen ions. You're much more likely to get the protonated species of weak acid. Okay, that'll be important to remember in just a moment. For the bases, when the base is by itself and it's unprotonated, this is in its uncharged state. So this will be the more lipophilic version of it. When it picks up a proton in a more acidic medium, you're going to find that it will have a harder time crossing those membranes because now it is charged, right? The protonated weak base is charged. So what does that mean? So we have two examples here, weak acid and a weak base. Then we have a lipid membrane. So imagine this is like the GI tract that it's trying to be absorbed through, right? It's one of these little microvilli or something. And again, there's going to be an equilibrium here between the protonated and unprotonated state. This is due to the actual pKa of the drug itself, and then also the pH that the solution that it's in. So if it was in the stomach, this would be like 2. The small intestine would be like 7+, so what you're going to find is that if it's in a solution where it's more in this unprotonated state, a solution that has a low amount of hydrogen ions, then you're going to find it in like a more basic solution, for instance, you're going to find it's going to have an easier time. Actually, it's just going to bounce right off this membrane here, right? Because those lipids don't really mix well with that charged molecule and just bounces right off, okay? When it's in the more of the protonated state, when it's uncharged, it has an easier time crossing over, and then it can then dissociate and do whatever. What's actually really interesting, and I'll talk about later, is that you can actually find that the pH of the solution on the outside here might be different than on the inside of the membrane, and that can actually cause trapping to occur. So for instance, when we talk about like pregnancy and lactation, this is how some drugs concentrate in the breast milk, because you can find that it'll be in the bloodstream, it'll cross over, and then it'll get into a state where it's going to be in this charged state, and then it can't get back out. So that's really interesting, because that can affect infants when they're breastfeeding and how much drug exposure they're getting. It might be much more than what even the mom was exposed to, because it concentrates so much and they are so small. But this is how the general process works. For a weak base, on the other hand, you're going to find that the opposite is true. When you put a weak base into a solution that has a lot of hydrogen ions, like a more acidic solution, it picks up the proton, becomes charged, and just bounces right off that membrane, right? If it is in a more basic solution where it is unlikely to be in that protonated state, then it can just cross right over. That same trapping effect can occur here as well. It just depends on the different membranes it's crossing over and what the solution on the other side sort of looks like. So the way we can look at this would be for the Henderson-Hasselbalch equation. So you could actually calculate this out and see what this actual ratio is between non to protonated species. I'm not going to do that. I'm not really saying that's going to be for our benefit, but I just want to show you what this looks like. So you can actually see that the pH of the solution is going to be equal to that pK of the drug plus the log of this ratio here. And so by altering this ratio, either making it more in the charged state or the uncharged state, or the opposite here for the weak bases, you can affect how well things get absorbed. Okay, that's basically what I'm trying to get at, is by changing this, because you can't really change the pK of a drug, but you can certainly change the pH of the solution that it's in, and that can have a big effect there. So if something, and basically the takeaway here too is that like dissolves like. So weak acids tend to get absorbed better in in acidic solutions, and weak bases tend to get absorbed better in basic solutions, right? So for something, I'll use aspirin as an example because if you've ever seen the abbreviation for aspirin, it's acetylsalicylic acid. So you kind of already know it's a weak acid, right? So you'll find that things like aspirin get absorbed better in the stomach where the pH is like 2 versus somewhere in the small intestine where the pH is closer to neutral or basic, because of the fact that when it's in a more acidic solution, you're heavily favoring these protonated species. It has a much easier time being absorbed from the stomach, right? So the exact opposite, though, if they have a weak base in the stomach, it's not going to get absorbed very well at all. And again, just kind of shows you the example here of where the pKa equals the pH of the solution. You're going to find that the balance between the protonated and unprotonated is equal. It's a 50-50 split. But let's say I were to dump some sodium bicarb into the solution and make it more basic, you're going to find that as the pH is greater than the pKa, you're going to be predominantly forming more of the A-, so the acid that's unprotonated, and the base is unprotonated, but notice here the base is not charged, but the acid is. On the flip side, if I started to throw some hydrochloric acid in there or something, or muriatic acid is another name, the pH drops below the pKa, you're predominantly forming more of that HA, which is protonated, which is non-charged, or you have BH+, which is going to have a harder time being absorbed because it is in a charged state. What's actually kind of cool is there are some drugs that are what we call tertiary amines, which means they have a permanent positive charge on them, and that actually makes them really difficult to cross any blood-brain barrier. In particular, the blood-brain barrier is what we care about for certain drugs. So for instance, if you were to look at like an antihistamine like Benadryl makes you really sleepy. Well, it does that because it can cross the blood-brain barrier and affect the CNS. But if you look at something like Zyrtec or something like Claritin, those are non-sedating because they have that positive charge permanently, and they actually can't even cross that blood-brain barrier, right? So that's why those are non-sedating for the most part. So little ways we can use this sort of concept to our benefits when we're designing some of these drugs here. So again, as I mentioned, something like aspirin, which is a weak acid, more lipid soluble in an acidic solution. Weak bases, something like morphine, tends to be less lipid soluble in an acidic solution. Okay, so remember, keep that difference in your mind between those two. That bases, when they're protonated, become charged. Acids, when they're protonated, become uncharged. And just to give you some examples of different drugs we have here, just to compare it, and they can range widely, and there's no need to memorize this graph at all. But you can see here, some examples of weak acids like phenobarbital and pentobarb, which are anti-epileptic agents, acetaminophen, aspirin, they can range pretty widely. Then you have some weak bases like morphine, cocaine, and ephedrine, things like that. So, and again, it's just affecting how well they get absorbed from different parts of the GI tract. But this could be affected at other places as well. If you're looking at drug absorption, say from the eye or from the lungs, like all of that can have a role to play. So, other means of having permeation occur here are through those special carriers. So I mentioned that some things are either too large or they are otherwise impermeable to these membranes. Well, how do they get across if they need to? Well, that's where our special carriers come into play. And so you'll find a lot of these in places like the blood-brain barrier, where usually you can kind of think about these as being sort of like the bouncers at the door of a really hopping club, right? So like all these people, all these molecules, they want to get into the brain. It's the hottest joint in town. We got these special permeators, carriers that are saying like, no way, we're kicking everyone out. And so that's where a lot of these amino acid carriers are really important, because they can either shuttle things in that need to come in, like cool people, or they'll kick all the other people out. And so there's actually efflux pumps that can do the same thing too, right? Another place this is really important, especially in the renal tubules. And especially like in that proximal convoluted tubule, there's a lot of transporters that either move things into the filtrate, into the eventual urine, or back out. Yes, I'm very familiar with hopping clubs as well. Thank goodness, because I just want to make sure I wasn't the only person getting into all these cool clubs, because you're getting kind of lonely, and they want to kick me out because I wouldn't wear my face mask, or I at least wouldn't keep my nose covered, because that's like the cool way to cover it or to wear it. But whatever. Those people are just, they'll get with the style eventually. Other things it really is hard being cool, Sydney. Thank you for being able to commiserate with me. Just cut a hole in it. Yeah, I've seen a few of those too. Don't get me off on a tangent about masks. It's ridiculous. But regardless, I like the people that take their mask off to like sneeze or to like cough. That's really fun too. Anyway, so the thing with these special carriers too is that it's not governed by Fick's law, right? So because there's only a given number of transporters, it actually becomes capacity limited. So they can either become saturated, it also requires energy, and it also means it can go against the concentration gradient. There's also a chance too you can have things like drug interactions that occur here, and I've actually you can find certain ones that will happen to where you can see some pretty significant effects. And so I'll just give you a brief tangent here, because I think you guys may appreciate a tangent every once in a while. So, there was a lady one time who had overdosed on the drug Imodium. I don't know if anyone knows what Imodium is, but it's loperamide, and it is technically it's an opioid, and it works for diarrhea because it actually slows down GI peristalsis. But use it for diarrhea, absolutely. So the interesting thing though is it doesn't really affect the CNS. You don't see like the analgesia effects. You don't see the euphoria and stuff, because the brain has these transporters that will efflux that out of the blood-brain barrier. So if you imagine you had the blood-brain barrier sitting here, you'd have these transporters that sit in. So if any loperamide, so imagine this is your loperamide, gets in, it would then be able to then be effluxed back out, and then you would not get any of those effects from it. And so there's this lady who must have either read online, or perhaps she was a pharmacologist in her off time or something like that. But she read that there was a drug interaction that you could take advantage of for these purposes. So she would actually ended up taking it with a drug called cimetidine. And cimetidine is actually a drug that is used for, it's like Zantac before it got taken off the market. It's used for heartburn. Basically, it's a histamine 2 receptor blocker. But one of the interesting things that cimetidine does is it actually inhibits a number of hepatic enzymes, but it also inhibits this pump here. So what she actually did is took a whole lot of cimetidine to shut down this pump, and then took a whole ton of loperamide, like just boxes and boxes of this stuff. And again, if you were working at the CVS or something, you wouldn't think anything of it. You just think, wow, that lady's got a lot of diarrhea. But she ended up having so much getting over. They found her comatose. She was in torsades, which is a very particular arrhythmia that you can see with like QT prolongation, and it vented and nearly died, if not for the intervention of EMS and the ICU crew and everything to help manage that, and a lot of magnesium for that arrhythmia. But anyway, so actually she took advantage of that drug interaction for that one specific purpose. Now, I would not recommend anyone do that because obviously she did not have a very good time with it, but it goes to show you how these transporters can be quite important, not only to get things into a membrane, but also sometimes to keep things out, right? So here's the example of that pump that I was mentioning there. This is the MDR1, or the multi-drug resistance transporter. Another name for this is the P-glycoprotein. So if you ever hear like PGP, that's what I'm mentioning there. And so basically this PGP is able to work as an efflux pump in a lot of places. So things like the brain, as I mentioned, the GI tract is another important one. And another thing you may find interaction that's pretty notable is this interaction with grapefruit juice. And you're like, well, why would grapefruit juice have any effect on drugs? And it's actually because there is a compound here, actually one called naringin, which will actually help to inhibit this pump itself. And so if you inhibit these efflux pumps, that can be not great, because what you end up having is that these drugs that would normally when they're dosed, we take into account the fact that these pumps are working, they end up getting really high levels of the drug because not as much of it is being effluxed out. And so the levels get really high, and that's why they can develop very significant things like hepatotoxicity and rhabdomyolysis. It's not great. And so statins are typically used for hyperlipidemia, right? And what kind of patients have hyperlipidemia? Usually older patients. Who likes grapefruit juice? Probably older patients too, right? Because that's one of the few things that still kind of tickles their taste buds, at least from what my grandparents would tell me. But anyway, so again, these are these things you'll learn about, and like, why do I need to educate my patient about grapefruit juice? Well, this is exactly why. It's because of these special transporters. Here's some examples. One of hepatocytes, and how this actually can work with the biliary tract to expel drugs. So this will be a portion of excretion we'll talk about later on. This is going to be important in the enterocytes and actually kicking drugs out. In some cases, there will be transporters that also can help to absorb them. So we'll find these everywhere. Just know that they can be saturated, so they can be overwhelmed and be working at a relatively slow rate. If you have a lot of drug around, they can be energy dependent, and they can go against the concentration gradient. Those are kind of the three big things I want you to take away about those special transporters. Other ways we get stuff into the system would be with endocytosis and its cousin exocytosis. This is good for things that really don't get into the cells any other way. And so, for instance, they may actually have even cofactors that help out with this. But if you have things like B12 with intrinsic factor and iron with transferrin, basically it helps for the cells to kind of engulf the molecule and then pinch it off into a vesicle where it can then be released at some other time, where it can be processed, whatever the case may be. Obviously, exocytosis, this is really important with cells that have these vesicles full of things like neurotransmitters or hormones or whatever, and then they can then fuse those with the outer cell membrane and then allow the molecules to go out to the bloodstream, go over wherever they're going to go there. So again, pretty simple pictorial example of the exocytosis and the endocytosis sort of process there that happens. This is not as common with a lot of pharmaceutical products, but it can be important for things like iron preparations, which we know is good for patients with like anemia issues and things like that. So it does come up occasionally. So that's how things get into the system from a more kind of cellular based level. Let's talk about distribution. So once the drug is into the system, like, where does it go from there, right? And so the first thing we're going to talk about is this volume of distribution. So this is kind of a tough term for a lot of students to sort of understand because it's more sort of theoretical. It's not really like tied to a specific it's like a specific number or something like that. I mean, there is numbers here, but it's a little more conceptually difficult to get. So let me try to explain it. Basically, when you're talking about a drug that gets absorbed into the systemic circulation, by that I mean the bloodstream, not all of that drug is going to stay there, right? Some of it's going to be distributing out into the tissues, into the muscles, the fat, the brain, wherever it's going to go to is going to distribute out. Drugs don't just distribute out 100%. Some of them like to stay in the bloodstream. Sometimes there's an equilibrium there where drugs may really like to stay in the bloodstream, or they like to distribute really far out. So I know we talked about THC previously, how that has a high distribution amount because it's really lipophilic. And if you have someone who smokes a lot chronically, you're going to find that they develop those tissue levels of THC that can be positive, can still hold it for weeks to months potentially. That is what we're talking about with volume distribution, is how much things like to go out into that tissue and hang out there. So the weird part is kind of a theoretical number. So I can say something like, this drug has a volume of distribution in this patient of 200 liters. Well, obviously that patient doesn't contain 200 liters of anything, because that's a lot of liters if you think about it. But it's more of a theoretical number. It's trying to tell you basically the relation between the drug concentration in the blood and the rest of the drug that's kind of distributed out to the rest of the body. So this will make more sense when I talk about it in mathematical ways, and also give you some pictorial examples as well. So basically what we're going to see is that the volume of distribution, which is typically expressed in liters, is going to be equal to the amount of drug I put into the body, so whatever dose I'm giving that patient, divided by the concentration in the plasma, right? So it's not just as simple as taking how much volume is in the plasma and dividing it by the amount of drug you're putting in. That doesn't give you that same concentration, because the drug just doesn't all stay there. Some of it goes out into the tissues, some of it will stay there. And so that's why we use that concentration to determine really how far is this drug being distributed out. So a very low concentration in the plasma, meaning not much of it's left there to even measure, means that you're going to have a really high volume of distribution, because it's all distributing out to the tissues, right? Because the drug that you're giving doesn't really change as long as you're keeping all other things equal there. So again, looking at VD equals dose, which is that total drug in the body, over C0. C0 is what I'm going to term as the initial concentration there in the plasma. So that's what those variables are defined as. So let's give an example here. So let's say I give 25 milligrams of a drug, and I go ahead and get a plasma concentration immediately after, and it's 5 milligrams per liter. Well, basically I can just divide that out, that 25 divided by 5, and then notice the milligrams will end up canceling out, and then I have liters left over. So that volume distribution for that particular drug in that patient is 5 liters. Basically, that means that if your body was trying to clear all of that out, say from like the kidneys, it'd have to clear through 5 liters worth of fluid in order to get that drug out. Generally, what we're going to see is that high volume distributions, meaning that the drug is fairly lipophilic and likes to distribute extensively throughout the body. Things with low volumes of distribution tend to be more hydrophilic and tend to hang out in the bloodstream. Okay, that'll be really important. We're talking about clearance and half-life and all that stuff in just a little bit. So let's say we have 2 drugs here. We have drug A, which is hydrophilic. It likes to be in that blood supply. And then drug B is lipophilic and likes to hang out into the tissue. Okay, so let's give 50 milligrams of each drug to that same person, and then we're going to measure the concentrations right afterwards. So we give both drugs to the patient, and then we get a concentration. So drug A's concentration is 10 milligrams per liter. Drug B's concentration is 0.5 milligrams per liter. So we gave the same amount. We're saying you gave the same 50 milligrams. Why is there such a discrepancy here between 10 to 0.5? That's a big difference. So what we can see is that if you get the volume of distribution, you see that this one here, there's a lot of drug left in the blood to measure. It has a volume of distribution about 5 liters. So not a very large volume as compared to when you were to calculate VD for drug B, ends up being like 100 liters. So it's a much larger volume that your body's going to have to clear through the kidneys and whatnot in order to actually get rid of that drug when we talk about excretion, right? So what this tells us is because there's not much of it left to measure in the blood, it's gone out into the tissues to hang out there. Now again, does that mean that person actually has 100 liters of anything for this to distribute into? No. It just means it's probably concentrating out there somewhere in the tissues, like in the adipose tissue or something, right? It just means it's not there in the blood to really measure. And so typically what we do is we will, instead of having just a straight liters amount, we can go ahead and figure out, based on sort of an average population level, what it is in liters per kilogram. Because then I can take this number and multiply by my patient's weight and figure out what, what their specific volume of distribution is. And what's interesting here is you can see that with all these different drugs, that it can range quite widely. Heparin, which is a natural anticoagulant that we produce in insulin, well, they don't really get very far distributed out. You can see that it's only 0.05 to 0.1 liters per kilogram. And a handy rule of thumb is anything less than 1 liters per kilogram is considered to have a low volume of distribution. Anything greater than 1 is going to consider to have a high volume of distribution. And so you can see here it goes all the way up to even chloroquine, which is, cousin to hydroxychloroquine, if anyone's been familiar with covering the COVID stuff. That's a volume of distribution of 200 liters per kilogram. So that's an absolutely insane amount. None of it really stays in the blood. All of it's distributing onto the tissues there, right? So Kyle's asking, is that how they estimate how long a drug will have effect in the body? This is one component. We are going to get into the rest of those components in just a little bit. But yes, that is part of it when we're trying to figure out half-life and trying to figure out how long these drugs stick around for. So this is really important too. So imagine, I am a toxicologist, right? And so one of the things we like to know is whether or not we can use dialysis to actually get rid of some of these drugs. And so if I have someone who overdoses on something like theophylline, which is a drug we'll use sometimes in COPD or asthmatic patients. Kind of an old drug we don't use too much anymore. Or let's say for something, ethanol, right? They have relatively low volumes of distribution. When I'm dialyzing someone with a dialyzer, basically I'm taking the blood out of them, filtering it, and then getting all the bad stuff, and then putting that blood back into the patient, right? Well, if the drug is hanging out in the tissue, then it doesn't matter how much blood I'm filtering through. I'm not really going to get much drug out of the system. As opposed to if it has a low volume distribution and most of it's in the bloodstream, then I can dialyze that off pretty easily. So for instance, something like ethanol, I can dialyze off, but something like digoxin, propranolol, nortriptyline, these are things you cannot dialyze because very little of it's in the bloodstream, so much of it is out there in the tissues, right? So that's one real life example of how I decide whether or not I should recommend dialysis for a given overdose is based off of volume distribution. So it does come up clinically, even if you may not know why that is. This is some of the reasoning behind that. So let's do another example here. Let's say we have a 70 kilogram male patient, a pretty standard type of patient, and we're going to give them 100 milligrams of drug C. And drug C has a volume distribution of about 0.6 liters per kilogram, and we're going to give that IV. So we know that everything IV has 100% bioavailability, right? So we're just asking, what's his estimated plasma concentration? So you can actually figure that out, right? So you could actually figure out, okay, based off this these numbers here, I can estimate what his plasma concentration is going to be. And you're maybe like, well, why would I want to do that? Well, if you know that there's a certain range you're trying to shoot for in terms of saying, okay, I want to make sure I get the level high enough to be therapeutic, but I don't want it to be so high it gets toxic, this is where you can do that. And so those narrow therapeutic index drugs I mentioned before, that's where this comes up, right? So going off the original, we have volume of distribution equals D over C0. This is the dose. This is my initial concentration. One of the things I want to do first is figure out what my volume of distribution is for this patient. It says 0.6 liters per kilogram, but since I know his weight, I can figure out what it is for this specific person. So 70 times 0.6 is going to be my volume of distribution. That'll equal 100 milligrams, which is the dose I'm administering. And then I'm going to get my C0. So then I'm going to rearrange everything. So eventually it's 42 liters equals 100 milligrams over C0. I then flip that around such that 100 milligrams is divided by 42 liters, right? So now I can say, okay, well, I know what apparent volume the drug is going to be filling. So I take that 100 milligrams divided by 42, and then now I have 2.38 milligrams per liter. So then I can reference that back to the therapeutic range, and if it, say, was between 2 and 5, then that would be an appropriate dose for the patient. If it was, say, between 5 and 10, then I would know that 100 milligrams is not going to be sufficient to get to the levels that I'm looking for. Because the patient's volume distribution hasn't really changed. I'm not going to be doing anything to change it. Not to say that it doesn't change, because patients can undergo a lot of different physiologic changes that can affect this, and I'll talk about those in just a moment. So what are things that can affect that volume distribution? What are some things that can vary? Because, I gave that number, some of those example numbers there of heparin's like 0.05 to 0.1. That's population averages, right? And we know that we're not dealing with healthy people all the time. We might be dealing with people who are sick and have some alterations in their volume distribution. So think about things that may affect VD specifically. So for instance, anything that's holding the drug in the bloodstream, say for instance plasma protein binding, that's a really good way to help reduce volume distribution. So if I have albumin sitting there and it's binding up 90% of the drug, that's really going to sequester a lot of that in the bloodstream such that it's very easy to measure, and that's going to help to reduce my VD, right? Dehydration will do the same thing. So if you have less total body water, it's going to concentrate everything in the bloodstream because you need to be able to perfuse your brain and your heart, right? So that's another thing that will decrease VD. And then VD can be increased by anything that's increasing sort of extra volume out in the tissue. So for instance, if I have renal failure, or if I have liver failure and I have someone who has like ascites, or maybe they have reduced serum proteins due to poor nutrition or something, and they're having all these fluids leaking out into the tissues. Or I have someone who has sepsis and the third's spacing a lot of fluids. Because there's now more fluids for those drugs to partition into, then you're going to see that increases VD. Okay, so these are just some examples, but there are certainly others that are out there. And, I've had students ask before, well, is having a high VD or a low VD good? I say, well, neither. It's just a feature of the drug. It's just like saying is having brown eyes or blue eyes good. That's what it is. And so we dose the drug around those sorts of things, just knowing that this is how it's going to act within. That's its nature. That's what it's going to do in the person's body. So Moving on, so we know where the drug is distributing to. Now we get into how it actually gets metabolized. So what's going on with this? So basically, there's going to be mechanisms that allow us to either terminate the function of the drug or at least alter its biologic activity. That's essentially what the metabolism is doing it. And in general, when we metabolize something, our goal is to try and get it prepared for elimination, whether that's through the biliary tract, whether that's through the kidneys probably being the most predominant one. But that's what it ultimately is trying to do, right? Get it more water soluble so it can be filtered by the glomerulus and get eliminated through the kidneys or sent out through the biliary tract. And so what you tend to find is these metabolic reactions are usually deactivating. That may not always be the case. We'll talk a little bit about things like active metabolites later on. That can be an issue. But that's essentially what we're doing here, right? And so the main place we're going to see this is going to be in the liver. So we'll talk much about the liver enzymes there. So just like with most drugs, when you metabolize them, they become inactive. Sometimes you'll have what we call inactive or active metabolites, and they can still work just as well, or sometimes even better than the parent chemical. I probably mentioned this, I think probably in the first lecture, but there's also something called prodrugs. They're really important because these are actually going to be inactive in their initial state, but they have to be activated through metabolism. So for instance, like your ACE inhibitors, like lisinopril or enalapril here, it actually gets converted to enalaprilat in the liver. So when you take it orally as a tablet, it's actually inactive, it doesn't do anything. But once it's absorbed, gets processed through the liver and turned into enalaprilat, now it can work as an antihypertensive. I mentioned codeine before being converted into morphine via some liver enzymes, or even lisdexamfetamine, which is Vyvanse, which is very popular. ADHD medication gets converted into dextroamphetamine. So these are all inactive products being converted to the active components there. So you can find liver metabolism is going to be depending on the drug, how it works, right? So as I mentioned, the liver is important. There's other places where things can be metabolized as well. So you may find limited metabolism in the lungs, the GI tract, places like that. But we're going to find is that the lion's share of it's going to be the liver. That's where we're going to talk about this most. And so anytime the liver is modifying a drug, we're going to call those metabolites, right? And ultimately the goal is to get rid of it, right? So either deactivate it, make it more water soluble, and get it ready for excretion. So there's two main types of metabolic reactions we're going to talk about. There's what we call phase 1 and then phase 2 reactions. Typically, you want to think about phase 1 reactions as being anything that's going to typically uncover functional groups. Maybe it's getting it ready for a phase 2 reaction, or it's making it more water soluble, right? Trying to uncover some polar functional groups. And so the main classes of reactions are going to be oxidation, reduction, hydrolysis. We are going to spend the majority of our time talking about oxidation. This is going to be the most important metabolic pathway we're going to talk about. So I'm drawing focus here because this is going to be the most important one we're going to talk about. So just keep that in mind. And that's going to include our cytochrome P450 enzymes. I'm sure many people have heard of CYP P450. This is what we're going to spend the most time talking about. Now, there's others that are out there. There's things like esterases and hydrolases and all of that. But when we actually look at the numbers, you're going to see that CYP P450 is going to be just the most important one out there. So then we have phase 2 reactions. So phase 1 is really trying to modify the molecule, uncovering those functional groups, those sorts of things. Phase 2 reactions is where we're adding something onto it. So we're adding a sulfate group, we're adding a glucuronide group, or we're conjugating glutathione to it. All of that is to increase water solubility. Okay, so we're adding something onto it to make it more water soluble so that it can be filtered through the kidneys and eliminated, right? So, and again, you can imagine in some cases you'll find that drugs will go through just phase 1 reactions. They may just go through phase 2 reactions. They may go through both, or in some cases they may not go through any, right? You may have some things that are just metabolized in the bloodstream by plasma esterases and things like that. But for the most part, we're going to see it's either going to be one or both of these phases of metabolism are actually going to be occurring here before excretion actually happens here. So you can imagine how this actually occurs when you have these products coming through here. Again, when you look at these, you're going to develop these metabolites, right? So either phase 1 metabolites or phase 2 metabolites. And again, remember, phase 1, we're modifying the molecule, usually make it more water soluble. Phase 2 metabolites, we're adding something onto it, right? This is the metabolism of acetaminophen. And so this is a good example of how drugs can go through actually multiple pathways. So here is acetaminophen, the original molecule. You will need to be able to draw this out on the test, so you probably want to learn what this looks like to draw. I'm just kidding, you don't have to do that. But what I want to focus on is that normally when it's being metabolized, it'll go through a lot of phase 2 reactions, right? You can see about 60% of it's going through glucuronide conjugation, about 30% of it's going through sulfation pathways, and this is all good. Yeah, don't get too scared. I do that quite often, so hopefully not too gullible. Otherwise, my class might be a little anxiety-inducing. But yeah, biochem flashbacks. Let me tell you what. You guys are lucky you're not in pharmacy school. I had a class called MedChem that I had to do for the first 2 years, because my schooling was 4 years long, which means they could really extend out the torture there. And the class was MedChem, and this is all it was learning these different reactions and actually drawing them out. And you know how much of that I use today? Close to none. Just a little bit that I teach you guys here is the majority of it. But yeah, so we had to learn how to draw a lot of different reactions there. But regardless, for our purposes here, I just want to illustrate kind of the processes going on here. So looking at acetaminophen, I see a lot of it is going through these phase 2 reactions, right? You see a little bit of it actually goes through this cytochrome P452E1. This is a phase 1 reaction, as I mentioned. It's an oxidation pathway. And what's interesting is you actually form this intermediate. It's called NAPQI, NAPQI. And then that is then detoxified by going through a phase 2 reaction. So you see here it goes phase 1 into phase 2. A lot of it goes through just different phase 2 pathways. Now it goes through phase 1 to phase 2, and then you get rid of it and eliminate it through the kidneys, right? What's interesting, though, and what I care about this because I'm a toxicologist, is that Tylenol overdoses are fairly common. And so what happens when someone takes a ton of acetaminophen is they end up overwhelming these processes here. You run out of sulfate groups to add on, you run out of glucuronide to add on. And so what happens? Well, instead of just 5 to 8% going through this pathway here, you end up having a much larger percentage. And then you actually deplete this pathway too. So then it's just going through this CYP2E1 pathway, and you're forming all this NAPQI, and this is what causes the liver dysfunction and eventually brain, heart, kidney dysfunction as well, that happens as a result of Tylenol poisoning. It's all a result of this toxic intermediary, right? And so if you don't have this pathway here to work, then you're going to develop liver injury. So anyway, just to illustrate the point of that drugs can go through phase 2, phase 1, they can go through both, they can go through multiples. It just depends on the drug, right? And so you can see here just some of the different types of transformations that occur here. Things like alcohol dehydrogenases, things like glucuronide conjugations. There's a ton of them, right? The main one we're going to focus on, though, is really going to be the CYP450 because, one, the majority of drugs go through this pathway, and then two, this is where we see the majority of drug interactions that we're going to be running into, right? So anyway, once the drug gets absorbed through the intestine, it gets delivered to the liver via that portal system, which we are familiar with, right? There, you're going to find the metabolism via various liver enzymes occurs here, and you're going to find that the concentration of a drug gets reduced before it gets to the systemic circulation, right? So let's say I just absorbed it and it got sent to the liver. That's that liver tax that I was talking about, and that's that first pass effect that we were mentioning, I think, during the first talk or whatever. And so, again, it's very variable depending on the drug you're dealing with. It may be 10% first pass effect, maybe on 100%, and the drug's not even good via the oral route because so much of it gets metabolized through the liver. And then you can actually modify this by going through different routes. So I like ethanol as a really good example of this because the absorption actually varies greatly depending on where you send it through, because there are means of bypassing first pass effect. If I take it orally, yeah, you're gonna get the liver tax, right? But what happens if I were to say insert a suppository rectally? Well, it gets absorbed there from that thin membranes there, and it largely bypasses the liver. So that means you get much more bang for your buck, essentially, because more of that drug is being actually distributed out to the tissues prior to being metabolized in the liver. So you can do this as well with things like sublingual drug absorption. You can obviously do this by giving IV. I've seen inhalational products that bypass first pass. And so that's why you can see that looking at ethanol, the absorption varies greatly depending on the route you're talking about. So for instance, if anyone's ever heard of a vaportini, there's a means of actually vaporizing alcohol that way you can inhale it, and it goes into the really large surface area of the lungs and it gets absorbed relatively well, right? That's one way to do it. There's been cases, actually fatalities that have occurred before, where actually patients have done either like beer enemas. So if anyone's been in a frat before, perhaps they're exposed to that. Who knows? Cases of patients who have actually soaked things like tampons in alcohol and actually inserted those vaginally or rectally. And what's really interesting with that is they don't realize that first pass effect is being bypassed. Imagine a teenager or a college student doing this is probably not thinking about the pharmacokinetics of alcohol when they do these things, right? So what happens is they bypass the first pass, and normally when you're absorbing alcohol orally, a pretty big chunk of it gets metabolized in the liver first. So now they're getting way more alcohol for every little bit they put in their system via these alternative routes, and they get way more CNS depressed. So you'll find them either passed out, you'll find them dead sometimes from respiratory depression because they absorb so much of it. So again, rule to the wise, hopefully you don't do any of these other alternative routes of alcohol absorption. I would not recommend those. But also you can do this with other drugs too. So just depending on the route you're giving, the dose may change based on that because of the fact that you're bypassing the first pass effect. So don't say it didn't teach you any good life lessons out there, right? So getting into the CYP450 system here. So again, this is an endogenous biosynthesis and catabolism pathway, right? And so it's involved in probably like 50% of drugs out there get metabolized through the CYP450 system here. And so being able to understand it and understanding especially a lot of the interactions that can occur here will help to determine one, intensity of drug effect, and then also the duration of the action of the drugs. So if I'm metabolizing things faster, I'm probably not going to get as much, the drug's not going to stick around as long, thus the duration of action is going to be lower. If it's slowed down, then maybe the drug's sticking around for longer and I get more action out of it, right? And so there are actually over 1,000 individual enzymes that we know in the P450 system, and roughly more than 50 or so are functional in humans. And how we break them up is basically off of their amino acid sequence, and you find there's many different forms of them, a lot of different families and subfamilies, and we kind of organize them based on that amino acid sequence. So basically how much homology they share with one another kind of puts them into these different categories. And so to give you an example, let's look at the CYP2D6 enzyme. So this is the enzyme name itself. By looking at the CYP, you know that it's a cytochrome P450 enzyme. By looking at the letter here, the family that it shares, so roughly 40% homology. The D is the subfamily, and then the 6 is the final individual enzyme itself, right? So when you see 2C9 and 2C19, those two share a lot of similar homology, but the actual individual enzyme itself is different, right? Versus if you saw 2D6 and 2B6, those are in different subfamilies. They actually even share less homology than 2C1s, right? So I'll give you some different examples of these. You'll learn as we kind of go through this. You'll kind of have a familiarity with a few of these more so than others, just because they're clinically much more important. And so here's an example of many of the more common ones you run into. So things like 1A2, 2B6, 2C19, 2D6 is a good one. And then you're going to see sort of like the king of CYP enzymes is going to be 3A4. This one is super important. If you don't know any other CYP enzymes, by the time you get out of my class, you should know at least CYP3A4, because this is responsible for majority of the drug interactions we're going to run into, as you'll see. So a couple things I want you to note with this chart here is, one, we have the substrates. So these are things that are metabolized by the individual CYP enzymes. We're going to have things that induce those enzyme systems. When I say induce, it actually means that it upregulates and it causes it to be there to be more enzyme around, so it's metabolizing more efficiently. And there's inhibitors, things that are slowing down the action of the enzyme to cause drugs to stick around for longer, right? So for instance, if I was looking at, let's say everyone was having a good 4th of July, they're enjoying some nice charcoal broiled foods here, right? This can actually end up inducing 1A2. So if you happen to be taking caffeine, for instance, this can actually help to speed up the metabolism of caffeine, and maybe it doesn't work as well for you anymore. Maybe it's actually starting to, you're having to slam 2 cups of coffee versus 1, for instance, to get the same effect. That could be a result of an induction sort of interaction here, right? Let's say, for instance, we're looking at 3A4, because this is, again, you just see the list of drugs that it metabolizes, a huge number, right? There's a lot of different ones that will either induce it or inhibit it. This is where the grapefruit juice comes into play. So you can see your grapefruit juice will end up affecting things like heart medications, things like the statin drugs I mentioned before. It can affect things like antibiotics, like macrolides. A ton of different things here can be affected. So it's important to know because you can either increase the metabolism, leading to lower levels of the drug, meaning they might not be as effective, or it can slow down the metabolism, leading to higher levels and actually leading to more toxicity, right? See, it sounds like the name of a robot from Star Wars, C-3PO. Yep. So we have Set-3A4, who's a good buddy to R2-D2. Yep. So, anyway, so this is important, and actually sometimes we can use this to our benefit. There's a really cool one where patients with HIV, if you ever look at some of the documentaries about the drug development for HIV, is really kind of fascinating, because if you think about it, like, HIV's been around since the 80s. It's going on like 40 years now, and like it's really just been revolutionized over and over again. But one of the cool things we were actually using was one of the issues with patients taking HIV medication regimens is that you'd have to at least take like 3 or 4 medications. You're taking them like 4, 5, 6 times a day, and you basically spend half their day just taking their medications. And we actually harnessed one of these interactions to boost levels of some of their drugs so they didn't have to take them as often. So there's a drug here called ritonavir, which we would put with some of their other HIV medications to boost their levels, so that way they had to take them less frequently. So kind of a cool way to use a drug interaction to help with compliance for these patients who already had enough to worry about managing their disease and then taking all these drugs on top of it. So pretty interesting if you ever get a chance to look at that. There's a lot of documentaries out there about that whole process. Anyway, so looking at some of the different enzyme systems here, you can see that 3A4 is like half the whole pie here, right? So again, very, very important. There's some other good ones as well that we'll note, like 2D6 is frequent. And there's a few that are more specialized that are for specific drugs that are quite important, and we'll cover those in Pharm 2 and 1 when they come up, right? Here's another graph just kind of showing you the breakdown of a lot of the other enzyme systems here, some of your phase 2 reactions. It's a little more even split. So, but again, if you're taking away anything from this class, it's going to be CYP3A4. So we'll see that some drugs may be metabolized in other areas too. So for instance, like the gastric acids, there's a set of drugs called proton pump inhibitors, PPIs. If you ever look at those, and I think I might have mentioned this in the first lecture, but they actually come in a little capsule, and inside the capsule you'll see all these little tiny beads that are in there. And what's cool about that is that those beads are actually acid stable. So what happens is they get taken orally, capsule breaks open, and those little acid stable capsules pellets will actually go through the GI tract, go through the stomach where the pH would normally destroy the drug, and then once it gets down to the higher pH of the small intestine, that increase in pH will actually melt away that coating and then allow the drug to be dispersed and be absorbed. So there's some ways we can actually formulate drugs to try to get around some of these metabolism issues here. But certainly things like digestive enzymes are important. This is why you can't give insulin orally, because it's a protein and it gets digested like other proteins do. Gut flora can be really important too. So there's issues where a lot of the vitamin K that we absorb is a result of actions of the gut flora, and so actually you can wipe this out either with like antibiotics and things like that, and that can actually affect vitamin K absorption, which is important because vitamin K, as you might know, is really important in the liver for appropriate clotting. You need this in order to form a lot of your clotting factors. So we'll talk a lot more about that when we get into warfarin next semester. So there's cases of liver disease too that can impair a person's ability to actually metabolize these substances here. So if you have like chronic hepatitis, if you have either drug-induced or alcohol-induced hepatitis, things like that, all these are things that can slow down metabolism and may extend the actions of the drugs that you are giving your patients. Other things that can affect metabolism include things like renal disease, potentially. Anything really slowing down blood flow and preventing blood from getting into the liver itself. So if you have things like CHF or something that's causing a lot of venous congestion, that's going to slow down the amount of blood getting sent to the liver, and less blood passing through the liver means carrying less drug through that liver, and so that can also end up leading to impaired metabolism. For instance, there's a drug we use called lidocaine. Normally you might think of lidocaine as being like a local anesthetic. You might put it on a wound or something like that. We use lidocaine also as a local anesthetic on the heart. It actually works as an antiarrhythmic. And so what you find, though, is because it's heavily metabolized in the liver, you have to basically give half the normal dose to someone with CHF, because we know they're just not presenting as much drug to the liver in order to get metabolized in the first place. So that's another big thing you'll see with that. Other metabolism factors can include things like the endocrine system. So we know that the thyroid has a major control on overall metabolism and catabolism in the body. So you end up finding the hypothyroidism tends to slow things down. Hyperthyroidism would speed things up. There are a lot of genetic factors that play a role here too. I mentioned those children that had upregulated CYP2D6 and how they would end up metabolizing too much codeine into morphine and then developing respiratory depression from that. Other factors can occur too, where they may have relatively low function of some enzymes, and that can lead to really dramatic effects too in terms of how long drugs are sticking around for. So it really depends. Some of these things we test for, some of these things we don't. It just depends on how prevalent it is in the population and how big of a significant interaction is going to cause if they do have it present. Some things are so rare that we just don't really check on it until a patient actually presents with an issue sometimes. Certainly diet and environmental factors play a role here. So like charcoal, broiled foods, as I mentioned, induces a host of enzymes. Grapefruit juice can inhibit them. And a lot of this stuff is very specific to certain enzymes, and we'll learn more about those as we actually get into it in the specific drugs. Certainly age and gender can play a role here. Age is probably going to be the more predominant one that affects us, especially very young and the very old. Very young patients may not even be expressing all of their CYP enzymes yet, and so we'll get into that in our special populations section later on. And as I mentioned, anything decreasing blood flow to that liver is going to slow down metabolism. So that's it for metabolism. Now we can start to talk about our drug elimination. So I think we got 40 minutes left on this. So and again, if you have any questions, please feel free to ask. Let me actually check the sticky board to see if there's anything there. It's a good stopping point. On slide 39, which is phase 1 and which is phase 2 reaction? Well, let's find out what slide 39 is. I'll discard that and see 39. Oh, here's 39. Yeah, so they're asking which ones are phase 2 and which ones are phase 1 reaction. So remember, anything that's adding on a molecule, so like glucuronidations, we're adding on a glucuronide to that molecule, we're adding on a sulfate pathway. These would both be phase 2. This is cytochrome P450, so you know that's a phase 1. That's an oxidation pathway. And then here, when you're adding on a glutathione, that's you're adding on something, so that is a phase 2 reaction as well. So 3 phase 2 reactions and just 1 phase 1 reaction here. All right. So moving on. All right, so now we've absorbed the drug, we've distributed it around the body, we have metabolized it, and now we're talking about elimination. So now we're getting into finally excreting it from the body, getting rid of it for once and for all. And so this is where the kidneys are going to come into play, and this is where biliary elimination is also going to come into play to a small extent, but we're mainly going to focus on renal function here for the most part. And so what you're going to find is that most drugs tend to be fairly freely filtered in the glomerulus, and hopefully cover some nephro stuff with Professor Kaplan already, but we'll certainly hit on more in this in terms of drug action in Pharm 1 for sure. We'll have a whole long time talking about the kidneys. And so anyway, so you tend to find most things get freely filtered, but once they're in the actual nephron itself, you may find that they can be reabsorbed. Some things don't get filtered very well, and they get secreted into the renal tubules, and so a lot of that is very dependent on the type of drug that it is, what transporters are present and whatnot, but it also can have to do with the actual charge on the molecules too, right? So just like the Henderson-Hasselbalch equation played a role in terms of absorbing drugs, they also play a role in terms of eliminating drugs. And so here's kind of the opposite. When you're trying to eliminate drugs, you don't really want to reabsorb them, right? Because you're trying to eliminate them. And so in this case here, with the GI tract, maybe we wanted things in an uncharged state so that way we absorb them easier. Now, if they can be in a charged state, they're much easier to eliminate. So urine pH ranges pretty widely. It can be anywhere between like 4.5 to 8. You tend to find a much bigger swing here than the blood, because like blood's normally like 7.35 to 7.45. Because the kidneys are really important in terms of maintaining pH status in the body, right? So this is better. The lungs are really good for kind of short-term management of pH. The kidneys are better for more long-term because it can control excretion of bicarb and things like that. And so depending on the pH of the urine, you can actually find that some drugs may be more readily reabsorbed, and some of them are more easily eliminated there. And so, for instance, with like weak acids, we tend to find that they're excreted faster in alkaline urine. And that's because when they're in that more basic solution, you're going to find that there's going to be a higher proportion that gets charged, and that they just bounce off those renal tubules because that positive charge on it, they don't get absorbed and they can be eliminated out, right? You can find that weak bases will get excreted faster in acidic urine, okay? This is again where I talked about that trapping effect that can occur as well, where you can find that by transitioning from one area to another, you can find that you can actually have trapping of the drug where it can actually concentrate in those areas. Probably breast milk is the most common one that you'll run into, and we can talk about that later. But you'll find that the pH of the breast milk may be slightly different than the bloodstream, and by causing that change, you can cause ionization to occur. And some drugs just like to concentrate in the breast milk, which is why we may have to do things like pump and dump sort of strategies where patient takes the drug and they abstain from breastfeeding for a period of time, and then they just dump that breast milk, and then they can breastfeed safely. So different things like that you may have to do as a result of these drug effects. But let's talk about like an aspirin overdose, because again, I like to bring things back to what I know, and that's toxicology. So with aspirin overdoses, there are a few things I get more worried about than when I hear about like a really significant aspirin overdose, because they can be pretty significant. But the way that I help a patient to eliminate aspirin more quickly is actually by altering the pH of the urine, right? So basically, aspirin we know is a weak acid, as I mentioned earlier, and what we can do is actually give the patient sodium bicarb. That bicarb is going to help to increase the pH of the urine, and it puts that weak acid into a more charged state, right? Because there's less protons around, and so it's just going to be in that A- acid, charged state. And so what happens there is that now it gets trapped in the renal tubules. They can't be reabsorbed, and now it just gets eliminated. And so we can do that where we have like less severe aspirin overdoses. We can actually help to increase the elimination and get rid of it that much faster. So that's something that I do and recommend when I consult for the poison centers pretty frequently. So now getting into clearance, basically when we talk about clearance, we're talking about kind of total volume of blood cleared of drug per unit of time. You kind of think about this like in mLs per minute, for instance. But when we're talking about elimination, we're kind of covering everything too, right? So you can talk about like liver elimination, biliary, all that, all kind of totaled up. We're mainly going to focus on the kidneys because that's kind of the biggest one to talk about, and also kind of the easiest one to calculate too. And so when I talk about clearance, this is going to relate to drug concentrations, right? And so again, if you can't clear something, those concentrations are going to remain steady or high because you just can't get rid of that drug. And so typically what we find is that renal clearance is going to correlate to renal function, right? Now, normally, we would do that by estimating their creatinine clearance. And so for those of you not familiar with creatinine is basically a byproduct of muscle metabolism. It is natural that we produce this. And the neat thing about it is that once it gets filtered, very little of it either gets reabsorbed or eliminated or secreted into the tubules. So basically what comes out in the urine is what got filtered. And so that's telling us how good their GFR is, that glomerular filtration rate, right? So what we would do on occasion is actually have them collect their urine for 24 hours and then measure that concentration of creatinine and be able to tell, okay, this is how much their creatinine clearance is, because you actually have a direct measure of it. But most people don't like to carry around a big jug full of their pee, and so because of that, we need a more convenient, easier way to do so, and that's where we use the serum creatinine. So we're using serum creatinine to determine creatinine clearance, which is going to be a surrogate for GFR, which is going to be a surrogate for renal clearance, essentially. So it's kind of a little bit obfuscated there, but it does work pretty well in practice, as you'll see. Normal serum creatinine can vary from patient to patient. 0.6 to 1.2 is pretty typical for most adults. But it's not to say that you can have patients on dialysis. Maybe they miss a day of dialysis, and they can be up to like 3, 4, 5. So they can get quite high as their renal function sort of diminishes. And so how do we determine what creatinine clearance is just based off of blood level? Say my patient doesn't want to, again, carry around a big jug of their pee. What can they do instead? Well, I can get a blood level of creatinine, and I can plug it into one of these equations. And basically these models were determined years and years ago. They probably should be updated, if anything, but they're still our tried and true models here. And again, I'm not going to have you calculate specifically what a creatinine clearance is on a test, but I do want you to know what the variables have to do with these calculations, right? And so here are two ones, like Cockcroft galt is probably the most common one we use for adult patients. The MDRD is used more so in like elderly patients. There are also other ones for children as well. You don't want to really mix these up and like use the kid ones for an adult because it's not going to be a good estimation of their renal function. But let's look at the Cockcroft galt. Again, most common used for adult patients. And you're going to see that creatinine clearance is equal to, first off, 140 minus their age. So what does this mean? Well, as their age increases, this number is going to get smaller and smaller. Thus, that means creatinine clearance is going to get lower and lower, right? So you know that with age, renal function diminishes, right? It's just a natural thing, a process of aging. So that's one feature too. So the older the patient is, the more likely they are to see that their creatinine clearance goes down. That's important too, because especially if you're dealing with like 80-year-olds, 90-year-olds, and they have very little muscle mass, the less muscle mass you have, the less creatinine you can actually produce, right? Same thing with like amputees and things like that. So you at least want to be able to take their age into account, because we know that there's not going to be a 90-year-old who has the kidneys of a 20-year-old unless they got a transplant or something, right? We also take into account their weight, so we'll factor that in as well. The higher the weight, typically the higher the creatinine clearance goes, up to a point. Obviously, patients with very large body habituses can skew this, which is sometimes why we'll make some adjustments, but that's kind of beyond our scope for today. But the other thing I want you to know is here in the denominator, you'll see it's 72 times their serum creatinine. So serum creatinine is in the denominator. That means that the larger this number is, because again, the worse your kidneys are, the higher serum creatinine is going to be. You're going to find the denominator is bigger. That's going to cause the creatinine clearance to go down. Okay, so higher the serum creatinine, the lower the creatinine clearance is going to be, and presumably the lower our renal clearance is going to be for drugs. Okay, especially for a lot of really hydrophilic medications, that's what's going to happen. Sometimes for these models, they'll factor in other things, and this is based off of the models they designed, based off the people that were involved in their study. So like the Cockcroft galt, I think, was done back in the 50s, and so people of the 50s may have changed a little bit to nowadays, but this is what they figured out back then, and this is still what we're using because it still works pretty good. And so here you notice they're multiplying by 0.85 if the subject is a female. This whole thing gets multiplied by 0.85. And you're like, well, why would you do that? Well, in general, you tend to find that female patients have a little less muscle mass and a little more adipose tissue as compared to male patients, right? Now, does this hold true for everyone? Absolutely not, right? So again, this gets you pretty close. It doesn't necessarily get you all the way. Like, what if you have a female bodybuilder, or what if you have like a transgendered person? That can change, right? And so because of that, this only will get you so far, but it does work fairly well, right? At least for our purposes of drug dosing here. If you notice here for the MDRD, you still see the same factors in terms of like creatinine and age and all of that. Here they actually factor in too if the patient is black. They actually that will bump up their GFR, which is kind of interesting. So again, depending on the equation you're using, they may ask you different questions, and that's what they're factoring in for. When they design these models, they're looking at different aspects of the patients and what helped the model fit the data as best as it could, right? So we'll talk more about that when we get into EpiBio next semester. So just you wait for that one. I know all of you are, that's what you've really been waiting for this whole semester, is to get to your epidemiology and biostats class for sure. But anyway, so looking at normal creatinine clearances, and again, patients can range here, so it's not hard and fast, but basically, in general, around 100 mLs per minute is usually pretty common for most healthy adults with normal renal function. Yeah, I'm glad you're pumped for it. My favorite analogy for that class is someone says it's like eating a bucket full of dirt, but I at least put a little bit of ketchup on there, so I make it a little more interesting. So that was pretty good. So anyway, so getting into clearance. Clearance is using that in conjunction with volume distribution helps us to determine our half-life. And what is half-life? Well, half-life is basically the time it takes to get rid of half of that amount of drug. Maybe instead of ketchup, we can use like some Yum Yum sauce from like Kobe's or something like that. Maybe everyone seems to love that stuff. So clearance, again, is helping us to determine the amount of drug we're eliminating per unit of time, whereas volume distribution tells us how much volume has to be cleared, right? So if it's something that's hydrophilic and has a low volume distribution, it's a smaller volume to clear than something that has a really high volume distribution, right? And so what clearance helps us to do is determine the steady state plasma level. So steady state's a really important concept we'll talk about here. When we get into elimination, there's two main varieties we're going to talk about. There's first order elimination, and no, that does not have anything to do with Star Wars, unfortunately. But there's also zero order elimination as well. Zero order is otherwise known as capacity limited. Most of the drugs we're going to talk about is first order elimination. Okay, so just know that most drugs are going to follow that, and that's the one I'm going to focus on mostly here. What you find with a first order elimination is that it's a constant percentage of drug per unit of time that is being metabolized. So if it's 10% per hour, it's always 10% per hour. It is independent of the concentration, but it's proportional to the concentration, meaning the higher the concentration is, the more drug you're metabolizing, because it's always 10%, right? Most drugs follow this. I'll show you graphs that will make this more clear in just a moment. When looking at zero order kinetics, this is usually where you've saturated your enzymes or saturated the ability to metabolize and eliminate that drug. So instead of it being a constant percentage per time, it is a constant amount of drug per time, right? So it may always be, for instance, with something like ethanol, it's always 20 milligrams per deciliter per hour. So that's independent of concentration. So that's kind of the interesting thing with ethanol, is that 20 milligrams per deciliter per hour is about a drink per hour. So if I know someone had 4 drinks, I can estimate it's going to be roughly 4 hours for them to metabolize that off. It doesn't matter if they have 10 drinks, it'll still going to take them 10 hours because the amount they're metabolizing is staying the same. Every per unit time, it's always the same amount of drug. So when you're looking at this in a graph form, if you look at time on the x-axis and the drug concentration on the y, you can see here with zero order, it's always the same amount of drug per unit of time. That never changes, right? It's a constant slope here. For first order, though, you're going to see more of this sort of curved line here, because as you're at very high concentrations, you're metabolizing a lot more drug, and then as you get to lower concentrations, that slows down, because again, it's always going to be the same percentage per time. So I'll show you some better ways to look at that as well. And so when we're focusing on first order kinetics here, you're going to see that basically we're going to be looking at the concentration of the drug, and we're also going to be looking at the rate that we're inputting drug into the system to help us determine clearance, right? So if I'm putting more drug into the system, I'm going to be getting more clearance. And then depending on my drug concentration, that's also going to have an effect on clearance as well. So, and when I talk about rate of administration, I can then kind of turn that into the dose I'm administering it, and then the interval. Interval just means how many hours between doses that I'm giving it. So if it's every 8 hours, that would be 8. If it's every 24, that would be 24 hours. So I can take this and determine what my clearance is going to be. And just note there's a proportional relationship between drug concentration and the amount of drug cleared per unit of time. So what does that really mean? I think this helps to make a little bit more sense. So imagine I put in 1,000 milligrams into a person, right, of whatever. 1,000 milligrams is in, and I go 1 hour. Okay, well, the fraction eliminated here is 15%. Notice it stays constant. It's always 15%. That first hour, I metabolize about 150 milligrams, right? It's 15%. Now I only have 723 milligrams left, so now I still metabolize 15%, so now it's only 127. Then it goes down to 109, then 92, then 78. And so what you notice here is that it takes, as the concentration gets lower, I'm metabolizing less drug, even though the percentage has stayed exactly the same. If I put more drug, if I put 2,000 milligrams in, well, then that first hour would have metabolized 15% of 2,000, right? So that's how it generally goes for these things. For first order kinetics specifically, right? If I were to look at zero order kinetics, this would be 150 all the way down, right? That would not have changed in the amount. Eliminate the percentage that would have changed. And so the way we can look at this, if you were plotting this on a graph here, so you have concentration on the y-axis and the half-lives here on the x-axis, remember that every half-life you're metabolizing 50% of that drug. So after 2 half-lives, I only have 25% left of the drug. After 3 half-lives, I only have 12.5%, and so on and so forth, till eventually have basically nothing left over here. Well, how do I determine what that percentage is, right? How do I know if it's 15% or if it's 10% or 20%, right? Well, basically what I can do is actually with the use of this elimination constant. That percentage is this elimination constant. And what I can actually do for first order kinetic drugs is I can take the log of the concentration, and that helps to actually straighten it out here on the y-axis, and then I plot it down as a straight line. And so what I can do is actually take the difference between 2 of these peaks and that difference in time and basically get the slope of the line here. By doing that, that's going to help me determine what percentage of drug is being metabolized for that given period of time there. So what I'm actually doing here is taking a peak and a trough level, peak just meaning the highest level that I took, and troughing the lowest level that I took, and getting that difference there, or that proportion there, dividing it by the change in time, and that gives me my KE, right? Another way to look at this, though, is to get KE equals clearance over volume distribution. Now, again, am I going to have you calculate this stuff like doing natural logs in your head on a test? No, I did. After the first year, they all revolted against me. I'm not going to do that again, okay? The point, though, you want to get, though, is like what these different variables, how it affects KE, right? So, for instance, if I increase my clearance, that's obviously going to increase my KE. Maybe that 15% goes up to 20%. On the other hand, though, if I were to say increase my VD, the volume distribution went up, that's going to cause KE to go down, right? Because it would be inversely proportional here. So this is going to have a direct effect on that half-life, though. So let me show you what that means. But let's take a look. Let's try to conceptualize half-life a little bit here. Let's say we have, again, this is the time it takes for drug concentration to drop by 50%. So let's say we have drug A, and it has a concentration of 20 micrograms per ml, and that's at 4 p.m. that we measure that first level. And then we get a concentration 4 hours later at 10 micrograms per ml. That's at 8 p.m. What is the half-life here? Well, you can just look at that pretty clearly and say, okay, well, I know 50% of the drug is gone. That's been one half-life. The half-life, and you look at the difference in times, 4 hours, right? Seems pretty straightforward. In practice, this is not going to be quite so straightforward. These numbers are not going to line all up like this, but that's the essential process we look at, right? Let's do drug B, though. Let's say we do 40 micrograms per ml at 8 a.m., and then we get a concentration of 10 micrograms per ml at 4 p.m. What's the half-life here? Well, again, I can already look at this and tell, okay, well, it went from 40 to 20, and then from 20 to 10. So that's 2 half-lives, even though I only have 25% of that initial concentration left, right? So it's 2 half-lives, and notice here it's gone over an 8-hour period. So again, 2 half-lives, or 8 hours divided by 2 half-lives, 4 hours per half-life, right? So again, the half-life is the same between these, but you can see how sometimes we're looking over the span of multiple half-lives and having to calculate this out. And again, just looking at this, you can see, okay, this might be 4 hours, might be 12 hours, might be 20 minutes. It just depends on the drug, and it varies quite greatly between different drugs. So for an instance, here are 2 antiarrhythmic drugs that we would use. So for instance, here's adenosine. This is used for supraventricular tachycardias. It has a half-life of less than 10 seconds. So less than 10 seconds, 50% of the drug's already gone. And so imagine if you needed to stop an arrhythmia and you're pumping this into a peripheral vein, say in the arm. If you don't push that very fast, most of that drug is going to be metabolized before it even gets into the heart to work. So it's a frequent reason why that drug actually fails the first time people use it, because they don't push it fast enough. On the other hand, though, you have something like amiodarone that is used for a variety of different arrhythmias. I used to just have slam it followed with 100 cc's of fluid. That's the best way to do it, because otherwise you will not get much effect out of that drug there. Very good point. With the amiodarone, the half-life is 26 to 107 days. So that means it's really varies quite widely depending on the patient in terms of how long that drug's going to be sticking around for. Again, 107 days, that could take in a whole year just to get rid of a significant amount of that drug there. And so again, this is just to give you an example how this can vary widely depending on the particular drug you're talking about. So how do we calculate KE? Well, how do you calculate half-life? Well, you use that KE. So essentially, this equation here, it's 0.693 divided by KE. But more importantly, that equivalence I showed you earlier is that KE equals clearance over VD. So plugging this in, you can see the half-life is equal to this 0.693, which this is not really important for our purposes, times VD over clearance. So what does this mean? So it means if I have a bigger VD, if I have more volume to clear, the half-life is longer, right? If I am clearing this more slowly, so say the kidneys took a hit and they're not clearing so well, this denominator is smaller, so this half-life then becomes larger. So really it's good to know the relationship between here, to know that clearance goes down, half-life goes up, and if volume distribution goes up, half-life also goes up. And the converse things are also going to hold true as well. If I increase clearance, half-life is going to go down, right? So looking at this, kind of talked about this already, that a larger VD is going to increase that half-life. A smaller clearance will also increase that half-life. Keep those relationships in mind, because it's really important. Because if I say, hey, a patient, is getting a certain dose, now their creatinine clearance has dropped by half, what is that going to do to the half-life of the drug? We should know that if creatinine clearance goes down, clearance is going down, so the half-life is now longer, right? So the drug's sticking around for longer. Now, is that a good thing or a bad thing? Depends on the drug and depends on what kind of levels we're hitting there, right? So that's going to directly equate to the steady state, right? Steady state is basically saying that the amount of drug we're putting into the system is equal to the amount of drug leaving the system, okay? And so basically what we're going to find is that by giving this drug to your patient, you're going to be able to eventually achieve a steady state, or an average concentration that, as long as these variables don't change, the patient can maintain for forever, basically. So what you're looking at here is that this average concentration is going to be defined as CSS, or concentration at steady state, is equal to the dose we're giving divided by the clearance times the dosing interval. The dosing interval could be continuous. It could be every 1 hour, every 24 hours. But we're going to see how this can modify that CSS pretty significantly. So, for instance, if I increase the amount of drug I'm putting into the system, well, that's going to raise up your CSS, right? If I decrease clearance and I can't clear the drug as well, that's also going to increase my steady state concentration. Or if I do things like increase my dosing interval, I change from every 8 hours to every 12 hours, and I give the body more time to clear a drug, that's going to drop my CSS. So this will make more sense when we're looking at a more pictorial example. And so you can see, although what these things are how they're going to play a role, right? How am I modifying these variables? What effect they're going to have here? And so as I mentioned, increasing the dosing interval is going to drop your CSS. If I decrease the dosing interval and I say I'm giving the drug more frequently, if I go from every 8 hours to every 6 hours, that is going to raise that CSS up, right? And in general, this is a good rule of thumb to keep in mind, is that the time to steady state is roughly 4 to 5 half-lives. And that goes for practically any drug you deal with. When you do your drug assignment, which I'll talk about a little bit later, you're going to see that, 4 to 5 half-lives holds pretty true for the majority of drugs. So imagine you were looking at a patient getting a continuous infusion of a medication. So you can see here this red line, they're starting off at 0, they're getting the continuous infusion. At a certain point, they're going to hit an equilibrium. And again, this is roughly 4 to 5 half-lives, where you're going to see that the amount of drug, because again, this continuous infusion is staying the same the whole time, right? Just looking at the concentration in the patient. It's going to rise up and it's going to hit an equilibrium point where the amount of drug I'm putting in is going to be equal to the amount that's going out. And presumably if I did not change the dose and the patient's clearance did not change, this would stay like this ad infinitum. I can come back 3 days from now, come back 3 years from now, and assuming nothing changed, they'd be at the same concentration, right? It's an equilibrium point. If you stop that infusion, then normal elimination happens and then your levels drop, right? Of course, not super convenient to do continuous infusions all the time. Most patients don't want to go home, carrying around an IV pole all the time. So obviously that's not really all that useful for us. And most of the time we're going to use what we call intermittent dosing, or dosing every intermittent period of time, whether it be 8 hours, 12 hours, 24 hours, whatever the case may be. And so what you notice is the blue line here is going to be the continuous infusion reaching steady state. This red line would be a more intermittent dosing. And so what do you notice here? So one, you give the first dose, you get a peak level, it starts to drop down, and then you obviously don't want to wait till it gets down to 0, because then the patient's not going to be getting the benefit of the drug. So then they give a second dose. So notice how the doses start to stack on one another. So they stack until you're roughly at 4 to 5 half-lives, and now you're going to be at the same steady state concentration. It's an average steady state though, right? You're averaging the difference between the peaks and the troughs. They'll very rarely be at that exact same steady state as the continuous infusion, but the average is going to work out, okay? So, but that fluctuation is there, right? And that can be important, right? Especially if the fluctuations vary quite widely. You may see that matters more for some drugs than another. So here's a good example of this. Here's looking at 3 different dosing strategies for the same drug. This dark line here is going to be the continuous infusion. You can see here we'll achieve that steady state level. Here is one, this light gray line, where we're going to be giving a drug every 8 hours, but at a smaller dose. And here's where we're going to be giving a very big dose of the drug, but it's only going to be every 24 hours. Okay. Notice here the steady state concentration, the average steady state, that CSS, is the same for all 3 of these. Okay. But what changes is this vacillation between the peaks and the troughs here. Those are going to be the big changes. So what you end up finding is that, in terms of compliance, people don't like to take medications very often. So if you can do something Q24 hours and it's still effective and safe, that's always going to be the benefit. But that may not always be the case depending on the drug, right? So for instance here, if I was looking at a drug and I was giving it every 24 hours, well, maybe it's an antibiotic and I have to achieve certain concentrations to kill off those bacteria. But for this dosing strategy, it drops down too low. So maybe those troughs are too low and that's not going to be very effective. Or maybe the peak levels might be too high, and you can see toxicity once you get above this level 20 here. You can see in either case it may not be all that beneficial. So from that standpoint, that's not great. but then having to say take a drug every 8 hours is not great from a compliance standpoint. So you got to find a happy medium between the two, depending on the drug and what the patient can tolerate in terms of how important. Like maybe for some drugs, these peaks don't really matter. They don't experience any toxicity. The troughs don't really matter either. So it just depends on the drug, and you may find a lot of different dosing strategies depending on that. Sometimes it's really critical they get that continuous infusion, and you don't want to go with an intermittent strategy. If you had someone who had low blood pressure due to sepsis, you're not going to give them intermittent doses of dopamine. You're going to give them a continuous infusion of dopamine to maintain that blood pressure right where it's at. You don't want to get those vacillations there between peaks and troughs. So here's another way to kind of look at it. Again, the same 3 sort of dosing strategies here. Here would be an example if you just looked at a single dose, sort of how it would end up being eliminated by itself. But if you notice here, by using the intermittent dosing, you get that stacking effect that happens till eventually you get to that steady state. Until, again, the average steady state will be the same here regardless. So what would happen, let's say for instance, like I was using amiodarone for a patient, say they're in VFib and they're likely to die without intervention in the next couple of minutes, right? If you recall, it takes, say, 4 to 5 half-lives to get to steady state, and I wanted to use amiodarone for that patient. We said it was anywhere between 27 to like 105 days half-life. On the low side, do I want to wait 100 days for that patient's level to get to steady state to be effective? Likely no, right? They'd probably be in the ground by then. So what do I do to get around that? Well, that's where we come up with loading doses. Loading doses are typically large bolus doses you're going to administer to a patient to get them up to steady state immediately, and then you follow that up by some sort of maintenance dose, whether that be a continuous infusion, whether that be oral dosing, whatever the case may be. So if you look at this black line here, this is going to be our CSS, right? This is our steady state concentration. The red line is our loading dose, and then this blue line is going to be the follow-up continuous infusion. If I just started the patient on the continuous infusion by itself, this is what the line would look like, and you would notice it would take a while to get to steady state. But by giving this bolus dose, this big loading dose up front, I get the level up to right where I want it immediately. You can notice as the loading dose is being metabolized and eliminated, now the maintenance infusion is starting to pick up the slack, and thus you never have a drop in this black line. Very handy for getting things done really quickly, and so you'll see this done for certain certain cardiac meds. We'll do this occasionally for certain like seizure meds and things like that. And so here's a good example of lidocaine being used for something like VFib. You would bolus with 1 milligram per kilogram per dose. So you give one big bolus dose up front, and then you follow up with an infusion of 20 to 50 mics per kilo per minute, right? So that way you get the loading dose, and then you have the continuous infusion backing that up. Works pretty well. Another example some of you may be familiar with is something called a Z-Pak or azithromycin. It's an antibiotic used pretty commonly for a whole host of upper respiratory tract infections, pneumonia, and all kinds of stuff. This does kind of the same thing. If you've ever seen a Z-Pak, there are 6 tablets that are in there, and you normally take it for 5 days in total. You take 2 tabs the first day, and then you take 1 tab a day for the next 4 days. Well, why do you take 2 tabs that first day? Well, because azithromycin has a long half-life. It takes a while to get up to steady state, so it end up taking 2 tabs first to get up to steady state, and then you follow it up with those 4 doses afterwards daily, and that keeps you at a point where you're still killing off those bacteria. Okay, so again, sometimes you've seen these things in the wild, not really know why they do them, but this is why they do them essentially. And so, as I mentioned, that maintenance dosing is used to help maintain that steady state concentration. And most of the time, it's not going to be a continuous infusion. A lot of times, it's going to be intermittent dosing we're using there. And so, to determine what that dose would need to be, you have to look at what concentration you're shooting for, how good the clearance is, and then what kind of dosing interval you want to go with. And so, you may find that for a longer dosing interval, I need a bigger dose because there's more time for that body to clear that drug. If I'm going with a shorter dosing interval, say only 4 hours, then I can go with a smaller dose, right? So all these things tend to be proportional to one another. Here's an example of a drug called clopidogrel or Plavix that we would use frequently for patients having an MI who are going back to the cath lab to have a revascularization procedure done. You can see here where each of these is a dose they're getting. They actually get loaded with several doses of the medication there, and then they get to a steady state, and then you follow it up with a smaller maintenance dose, and they can be maintained on this for years potentially, depending on what they require. So again, just another example of a loading dose strategy followed up by those maintenance doses. So looking at some of these variables here, looking at given that our steady state concentration equals the dose over the clearance time, the dosing interval, what are some reasons that we could have super therapeutic or concentrations that are just too high, right, causing a potential risk for toxicity? And how can we combat these, right? How can we deal with all these things here? Well, you can look at it, if, say, my dose changes, say my dose goes up, then yeah, maybe there's a dosing error. Maybe someone takes a double dose instead of their single dose. People forget sometimes and do that. That can raise your CSS and cause levels to be too high. If my clearance goes down, because this is in the denominator, that'll also cause my steady state to go up and could potentially lead to toxicity. Or if the dosing interval is screwed up and someone takes it, say, too close together, maybe they're taking it every 8 hours instead of every 12, for instance. All these things can end up leading to those super therapeutic concentrations. A lot of this has to do with making sure that we're dosing things appropriately, make sure the patient's educated on how to dose them appropriately. And the clearance part, we can't really change because I can't really will a patient's kidneys to work better, but I can at least monitor it. And I can't tell you how many times you see elderly patients show up at the ER for drug toxicities because they've been on the same dose, the same dosing interval of a drug for a decade, and no one went back and looked at the creatinine clearance to realize that had gone down. If that goes down, you can adjust the dose. You can adjust the dosing interval to prevent that from occurring. So that's why I really focus on not just, it's not a set it and forget it kind of thing. You got to follow these people over time and make sure that if no one's checked a creatinine clearance in a while, like maybe now's the time to do it, right? So other variables we can look at in terms of things that can lead to some interactions here. So with absorption, compliance is really important. Consider what kind of regimens you're recommending for your patients. Obviously, from a compliance standpoint, easier is better. So if you can do once a day dosing for things, or you can use combination pills, that's always going to be better. Because if they don't take it, then obviously they're not going to absorb anything. Looking at abnormal absorption can occur frequently from like drug-drug interactions. So we talked about before, like you can have fluoroquinolones, which are antibiotics binding up to calcium or binding up to iron, things like that. Or if certain drugs should be taken with grapefruit juice, make sure you're educating them to avoid that sort of thing. Note that with clearance, this is not something that we can address specifically by education or anything like that, but make sure that we're monitoring it, looking for changes in kidney, liver, heart function, all of that, and that we're adjusting things based off of the specific drug recommendations. When you're looking up your drug assignments, which I'll talk about in a little bit, you're going to find that for some drugs, you really have to heavily adjust for renal dysfunction. For some drugs, you don't have to do that at all. It just depends on the specific drug, right? And so real briefly, I want to talk about toxicities here. When you're getting toxicities from a drug, sometimes you can find that it's due to the same receptors, but just found in different tissues. So for instance, like I have a patient who I'm treating for pain, right? And I'm giving them an opioid like morphine. You tend to find that there's opioid receptors located in the spinal column, and that's what helps with analgesia. But also there's opioid receptors in the GI tract, and that's what causes all the constipation. It's the same receptors, and since I can't really separate those out, I kind of have to take the good with the bad in those cases there. Or for instance, you sometimes get issues where you have toxicities that occur based off of drugs working outside of their normal mechanism. So for instance, erythromycin is an antibiotic that normally works to treat and kill bacteria, but you can see here it also actually interacts with our motilin receptors in the GI tract and can actually lead to GI peristalsis. Can actually end up leading to cramping and diarrhea and whatnot. That's a common side effect of erythromycin. And so these super therapeutic concentrations can result from a number of different things, right? So sometimes you can find that these are intentional issues. Like I mentioned, that lady who was abusing that drug interaction between cimetidine and loperamide to her major detriment. Sometimes it's for attempted harm purposes. Sometimes they're trying to harm themselves. And then unintentionally, you can find that like kids get into medications. And again, for some drugs, even one pill can be very detrimental to a child. Or it could be related to things like their clearance changing with time. Or maybe they got dehydrated and their renal function went down. Things like that. Main point though is that there's a poison with everything, right? There's nothing that is without toxicity given the correct dose. Water is poisonous, oxygen is poisonous. It just depends on the amount that you're getting, right? And unfortunately, most substances don't have an antidote. So when you think about giving a medication, it's really important to step back and be, okay, is this most appropriate for my patient? Did I take into account all these factors here? Because once you give it, it is generally very hard to take back. You basically just have to give the body time to metabolize and hopefully provide some good supportive care for them in the meantime. Otherwise, you can't really do much, right? There's relatively few drugs that have an antidote that just reverses it, like Narcan. I wish we had a Narcan for everything, but unfortunately, it just isn't in the case, right? So anyway, that's it for this section. I'd like to take a few minutes to talk about your homework assignments, since now we've covered most of the topics here. So let me see. I need to get your class pulled up. All right, so this is your class. And if you look, I'm going to go ahead and see here. And again, if you have any questions, go ahead and put them up in the chat there. Okay, so everything should be unlocked, so that's good. Okay, so if you look at your assignments, we have 3 that are going to be due for this class. There's one that's due July 31st. We're going to talk about this at a later date, so don't worry about that one too much right now. There are 2 that are going to be due July 24th. This one here, the drug dosage calculation, this one we're going to talk about at the next lecture, so that'll be Tuesday. Next Tuesday, so that'll give us plenty of time to work on that. It shouldn't take you all that long once you kind of get the hang of it, so I'll talk about that next week. What I do want to talk about now, though, that you can start working on is this drug information assignment. Basically, you can see there's an assignment checklist or roster here. Basically, everyone has been assigned a drug, and I'm sorry if you don't like the drug you got, but it is what it is. It's completely random when I design this. So you'll find your drug, and then based off of that, you're going to use a drug reference. I recommend using Lexicomp. Lexicomp can be gotten to through UpToDate. Is everyone familiar with UpToDate? Let me know in the chat if you know what I'm talking about in just a moment here. I want to at least show you the assignment as well. So the assignment here is basically what you're going to be doing is going through and answering these set of questions, which is pretty much covered now at this point after this lecture. And you can find all this information in a standard drug reference. And so I want you to be able to just speak to them. It doesn't have to be the most in-depth answer ever. You might not understand everything you're reading, but try to write it down in the best way that you can at least understand it. And then, of course, you'll reference it with AMA style at the end here. I put a citation guide as well. So Christy knows how to get to it, but I don't see many other people. So I'll just show you real briefly just to make sure everyone is aware. So let's say we're going to go to, we got some sticky notes there too. So I've never used it, but I'm sure I can figure it out. Well, I bet you can too. Nova HPD library. So everyone should at least be able to get to the Nova HPD library, right? From here, you can get to your databases. So go to the HPD databases. Then you can go to U for UpToDate. And UpToDate is going to be a very important website you're going to get very familiar with, because it is a very good reference for basically anything you want to know about. If you want to learn about any disease state, anything you want to look up, it's all there basically. So you can go ahead and type in a drug. So if I wanted to do fluoxetine, I could look up fluoxetine, and it'll actually take me over to this drug information one. And this is actually a link to Lexicomp. Lexicomp is what I use, and they're owned by the same company, basically. And so basically you can go through and see all of these information. So you can go through and find everything that you need there. So I'll kind of let you go from there when you're doing that. Anyway, so that's how you find UpToDate, and that's how you find Lexicomp drug information. Let's see. It's false confidence. Yeah, it probably is, but you know, I'll have some things to talk about with UpToDate when we get into epi biostats and research methods later on. So don't you worry about that. So anyway, so I want you to start working on that, and you know, let me know if you have any questions. You know, basically just fill out the Word document and then upload it. In terms of sticky notes, let me see here. What was the answer to the half-life question to drug B? For drug B, that was again 4 hours. So if you go back to about half-life. Yeah, this one, drug B here, this is actually 4 hours. So it was 2 half-lives, 4 hours each. So even though it was over an 8-hour period, it was still 4 hours. So what do we have to know about families and homologies, e.g. naming of 3A4? Basically, I wanted you to know that there are a lot of CYP enzymes out there, and that's just how they're categorized. I'm not going to ask you what the percent homology is between a 2C9 and a 2C19. I don't really need you to know that. I would at least have you expect to recognize that, yeah, that is a CYP enzyme. I know that CYP 2C9 is distinctly different from 3A4, and that's different from 2D6. They're going to have different roles in terms of what drugs they're responsible for metabolizing and all that sort of thing there. So that's what I would say about that. And so, okay, that's all I wanted to address with the assignments. We'll talk about the drug calculation one later, and then later on after that, we'll talk about the prescription assignment. I haven't talked about writing those just yet. Any other questions I can answer for you at this time? If not, you're free to leave. Thank you for joining me, and I'll see you all on Tuesday. Looking forward to it. I haven't burned yet too much with all this talk of kinetics. Yes, you all have a great weekend as well. Thank you for joining. All right, I'll see you guys later.